Hello, everybody, and welcome back to another episode of Hybrid Healing Hour. Today, I'm so excited. We are going to be talking about how to utilize the emergency room. And we have our good friend and colleague, Dr. Larry Roycraft, with us today. So, Larry, will you please tell us how you got into this profession as an ER doctor, or a little bit about your background in general?
Sure. Well, I attended Southeastern University of Health Sciences Osteopathic School along with Dr. Brian. And actually, we both did a internship in internal medicine together. But I really was focused towards ER. Then I got into ER training and residency at LSU Charity New Orleans. Did a fellowship actually after that in emergency medicine and hyperbaric and diving medicine. And then moved back here to South Florida, where I'm from. And I just love the ER, and I've been doing it for 28 years now. And it's just always, every day is different. Every day is exciting. Every day you never know what you got to get. And
I'm sure you had some good experience at Charity in New Orleans.
A great place to train. We saw a little bit of everything, and lots of stories that my young residents and medical students don't believe when I tell them.
I could imagine.
It was a different world back then. So, even though we've titled this episode, How to Utilize the Emergency Room, we're really actually going to talk about the distinct differences between the hospital emergency room, traditional urgent care centers, walk-in clinics, and also freestanding emergency rooms, because people get confused as to when and where they should go for different problems. So why don't we start off, what's the difference between the emergency room, between urgent care, and between a walk-in clinic?
Well, the emergency room is physically part of a hospital. It's 24/7, 365. All services are available at that hospital. Surgery, obstetrics, anything you need, medical, cardiac, along with all the imaging, most of the imaging and workup and lab and ancillary you would expect. So that's the sickest of the sick. Now, patients would have to keep in mind that may be a little limited based on what services the hospital has.
Right, so not all hospitals are created equal.
Correct. My hospital here locally, I'm a regional trauma center, cardiac center, open heart, comprehensive neuro, but we don't have pediatrics or obstetrics. Now, that in mind, we will see kids, we will see pregnant women in the ER, stabilize, and then if they need more treatment, then the only thing is you would be transferred to another facility that has those specialties. So don't hesitate if you have a true emergency to go to the closest ER. We'll keep you alive and get you to where you need to go.
That's always good to have. And aren't there different trauma
levels?
Levels, yeah.
Yes, there are generally 3 levels of trauma. Level 1's the most serious. That has all services, which include basically the big difference between like a level 1 and level 2 is level 1, the trauma surgeon is in the hospital 24/7. They're not on call to come in, and usually it also has neurosurgical capabilities for brain bleeds and tumors. So in our county here, we have 2 level 1s, where one of them in the south, there's another one up north. And both are level 1s, there are no level 2s, but in other areas, large metropolitan areas, you'll have level 2s. Even in some more remote rural areas or places along the highways, you may see a level 3, which is basically like a stabilize and transfer on.
Right.
And there are, within each county, there are strict protocols and policies of who goes where, and the paramedics know to take. And even within trauma centers, we send things out even as a level 1. For example, most commonly we send people down to Jackson Memorial for burns, because we don't have a burn center. So very severe burns, we would go from the trauma resuscitation room, which is part of the emergency department, down to someplace. But for the most part, the level 1's a one-stop shop.
Right. And what are some examples of like a level 1 trauma? I know we mentioned I'm assuming like a very serious car accident.
Yeah, very serious car accident based on mechanism, based on injuries, based on vital signs, based on exam. We're very, in my area here in South Florida, we have a large retiree population. So we have a lot of issue with falls leading to fracture of major long bones. Head injuries, head bleeds are very good. Other things would be any kind of penetrating trauma, so gunshot wounds, stab wounds, construction accidents, anything where, it appears. And then also crush injuries, but a lot of different things. They've flown people from, the Coast Guard has flown us in people in Bahamas that have shark bites, so just anybody that needs the most critical care for some surgical traumatic injury in a rapid amount of time.
Wow. And what kind of training does it take to become an emergency room physician?
Well, obviously you have to go to medical school, but there's emergency medicine residencies, which last either 3 or 4 years. It varies. 4 years is the kind of original classic, like I did at LSU, but now the trend is to more a 3-year residency program. We actually have affiliated with a local university, so we have a EM residency that uses our hospital with a couple others in their area, so we would have residents in training as well. And then there are, as I mentioned, I did one, but there are a number of fellowships which are like subspecialty training, like Dr. Bryan's renal training. I did it with diving and hyperbaric medicine, a passion of mine. But we've had some of our residents do critical care from an ER perspective, and there's pediatric emergency medicine,
which is even a more subspecialty, I'm assuming. Okay.
Right, yeah. So you would do, if you're interested in treating children, and there are large centers that have separate pediatric emergency rooms just for children. You would either do pediatrics and a pediatric ER fellowship, or you could do adult ER and do an ER fellowship. So there's a number of those, but at least the 3 years.
Now, I know once upon a time, it was common for all specialties to work in the emergency room. There would be internal medicine doctors working in the emergency room, but now it's changed to the point where it's pretty much board certified emergency room trained physicians that work in the emergency room. Right?
That's correct, Brian. It's originally starting in the late 60s, early 70s when EM or emergency medicine started as a real specialty. Before, like Brian said, everyone in the hospital had to do their rotation. So you could come in with a heart attack and hopefully the ophthalmologist wasn't on duty that day. You would just be making frantic calls. So for a number of years up through the early 90s, there were a lot of doctors who were grandfathered in emergency medicine, so they could be internists or surgeons who practiced in the ER, liked it. Some practiced in previously, I want to say it was somewhere around 10,000 hours of ER experience. You could be eligible to sit for emergency medicine board, to be board certified in emergency medicine. But that's pretty much phased out. The only place you would see a non-EM boarded doctor would be in a critical need area or rural area where there just isn't enough to go around. And then you would have to be a board certified, internist, physician, et cetera, with an extensive number of hours of emergency experience.
And I know that besides emergency room physicians, a lot of emergency rooms now also have physician extenders, but they have different roles, right? They work alongside and they treat certain conditions. Tell me your experience with physician extenders.
Well, what you find, actually, we call them APCs, advanced practice clinicians. The nomenclature changes a lot. It's a moving target. It's a variability depending on the location and the volume and the acuity of patients. A lot of hospitals, the physician extender would just be another person on the schedule, and they would be picking up who's on first, who's on deck, the next patient up, seeing the simplest stuff and complex things in concert with an emergency physician. In my particular practice, because it's so busy and we have multiple practitioners at any one time, our extenders usually are in what we call our fast track or quick care area. The thought was you'd be seeing colds, sore throats, skin abscesses, lacerations, falls, back pains, but because of our patients, they see end up critical patients. They see patients that end up needing to be trained, go into the trauma system because of a head bleed from a fall or et cetera. So it's really variable. There are some areas of the country, very underserved areas, especially in the upper Midwest, where there are no doctors. There'll be typically physicians, associates, or other extenders working solo in a small ER somewhere, usually with a telemedicine backup. And there are some companies that specialize with ER doctors sitting in a room in Chicago with a bunch of banks, and they will be wheeling a telemedicine cart with a screen and microphone and speaker and talking to the patient, talking to the student, said, okay, I agree, you should do this, this, and this. But that's a very minor part. So extenders fill every role you can imagine.
And they have a lot of experience. I mean, they've been working thousands of hours, and I trust them completely when they see one of my patients and give me a report. Their reports are pretty good.
Like everything in life, it's variable to the person. I know our particular extenders are exceedingly trained because of our high volume and our high acuity. We only pull the best. So even within my particular company that staffs a lot of hospitals in the Tri-County area, our lead APC, who's the lead APC for the whole region, she will only bring in ones she thinks that can handle it because it's a busy place. But for the most part, most of us are going to hire someone that's good because in the end, we're also responsible. But unlike an office visit, I don't have the luxury always to eyeball and see every person they saw.
Right.
And they're trained well, and they know when to fly solo and when to say, hey, come look at this.
So you mentioned, this teleprompter, or with a doctor on the other line. I'm assuming that's at a low trauma unit. That
would be, for example, the last article I read, it was in Upper Peninsula of Michigan in like a 50-bed hospital with like 4 beds in the ER. Very low acuity. Now, anything can roll into any place.
Yeah, technology is going crazy right now, so...
Well, and just patients don't know they're sick, they go. We recently had a case presented at our National Leadership Conference. I work for a national staffing company as an assistant director in my facility. And they presented it as a brand new ER resident graduate, their second month in a freestanding ER along a major highway here in Florida. And there was a little party bus that got involved somehow in a drive-by. And the bus driver freaked out, saw a sign, a big H on a blue background, pulled into this freestanding ER with 1 doctor, 3 nurses, and a tech with 7 gunshot wound victims.
Wow.
And that could, because of the training we have, he was able to stabilize everybody, get them sent off to 2 different trauma centers in the area. So even in rural areas, even though they might be knife and gun club like I've trained in the inner city, they're more going to be industrial accidents, farm accidents, tractor accidents, which are massive injuries.
So you mentioned freestanding. So what is a freestanding ER? So
freestanding ERs have been around for a few decades. I worked in one in training in New Orleans, one of the first in that state. It is a building that is not attached to a hospital, but is a fully operational ER.
So they have CT scans, X-rays, like everything that a hospital would have.
Yes. Varies state to state on the regulations. In Florida here, the freestandings have to be associated or part of an existing hospital. In other states, Texas, where it's very big and one of the first places to take off, there are private groups that own their own ERs that have places. Because again, somebody cannot be brought in or admitted to a hospital. But typically, I'm on staff at 3 different freestandings in 3 different hospitals for my company in this county. And they all have a board certified emergency physician 24 hours a day. They have nurses. They have some, paramedics or techs to help the nurses. There's usually a respiratory therapist. There's a radiology technician. We have a pharmacist half the day on ours. We have CAT scan machine. We have X-ray. We have ultrasound available. Some have the tech there. Some you have to call the tech in. So with everything you would need we keep, for example, ours here, we keep the lab blood bank stocks a few units of O-negative blood if there's a massive, emergency bleed. The idea is you'd be seen, evaluated like you would in a regular ER. And if you go home, you go home. If you need to be discharged or admitted, you need to be coming to the hospital, then you would be transferred to a hospital, usually the hospital that runs it, but the patient always has a choice of where to go.
Right.
So, but they're very popular. They can be a good way. They're usually a good way to be seen if you're really sick. If geographically, they're usually in areas where there's not really a hospital around, so it could be convenient geographically. Typically, because of the nature of it, until people know about it, it can be an easy way to get in and get out quick, if you will. Because
that's what I was just going to ask if it has less wait time.
Depends. I know there's one in the northern part of our county that at times sees more patients a day than the main ER.
Wow.
Just because of where they picked a great geographic location that's in a dead zone of medical care. But it's a pretty good way to be seen, and they're very convenient. I and my wife, who's a nurse, send a lot of her friends when they call up her for medical problems, and they say, well, it's, you called your doctor. It's 10 o'clock at night. Listen, there's a freestanding in this area right by you. They're good doctors, they're good nurses, because generally it's the same crew that staffs the main ER will staff those.
Right.
Actually, sometimes better experience because they're like a premium job for nursing, because you may see a lot of people, but it's not as busy, and there's no administrators there. There's nobody coming around. So usually it's the more experienced nurses that have the seniority to get that plum assignment. So sometimes it's better nursing than the main ER may have.
I think you brought up a good point. For patients, as a general rule, you should know what's around you. You should know where the emergency room is that you would want to go to. You should know where the freestanding ER is. You should know where the urgent care center is, because you don't want to wait until you actually have an emergency to try to figure this out.
We see that a lot. There are a lot of people in our area that don't know. We don't hospitalize children. That's the one that always comes to mind. Sometimes because we're in South Florida and it's vacation, and why did you bring this kid with a fever here at 1 a.m? We're staying with grandma. We don't know. No problem. We'd love to see him. Mm-hmm. I've done a handful of deliveries in the last decade because people will come in who usually have no prenatal care, or even people that know just prefer because, I don't like going to hospital B because it's always a busy wait. Yeah, but you're 30 weeks pregnant. We can't come here. You shouldn't come here. We'll see you. But yeah, the patient, you should know an idea of what's around, especially if you have any kind of special needs. If you have a complex neurologic syndrome chronically, then you may know, to go someplace that's a stroke center or has good neurologic capabilities. If I have a special needs child, I may not want to go to a hospital that doesn't have pediatricians in the building, etc. Although the the old saying is the emergency physician's the second best doctor in the hospital. I'm the second best at treating kids behind the pediatrician. I'm the second best at delivering babies behind the OB. I'm the second best at treating heart attacks in the cardiologist. So that's one of the things that drew me to this specialty was a little bit of everything. I have to know a little bit, a wide knowledge, but I'm also have to know enough that I can treat patients correctly and at least get things going the right way until we can get a specialist if needed involved.
That's great. So let's talk about the emergency room first. Emergency room, there's certain reasons why people should go to the emergency room. People have to keep in mind emergency room visits are very expensive, and they should be reserved for true emergencies. The cost of a visit for a cold going to the emergency room is astronomical compared to going to see your primary care doctor or even a walk-in clinic. And you can expect long wait times in the emergency room. So for most minor things, I think most people should think my primary care doctor should be my first call, right? But after that, let's talk about some of the symptoms that are best evaluated in the emergency room. And I'm going to mention some things, and then you can expand on them a little bit. Let's start with chest pain or difficulty breathing.
That's a pretty standard. That's the number 2 reason for visit to emergency departments in the country is chest pain. A lot of times it turns out to be not minor or not major, it's minor, but you don't know, especially if you have any kind of underlying condition, any kind of cardiac conditions or any kind of medical conditions that put you at risk, then the emergency room is appropriate. Now, keep in mind, you say can be long wait times in the ER, but we are constantly striving to reduce that. In our group, in our network here, 5 hospitals in our county, we have reduced wait times dramatically over the last 5 years. Ongoing efforts partner with the hospital. However, it's not first come, first serve. It's a good thing if you wait in the waiting room, because if you walk in and they rush you right to the back, you're having a bad day. You don't want to be the first person in the morning you want to have someone bump you from surgery in the morning. It means I'm not as sick as them. So, but chest pain, it could be as simple as an allergic reaction. It could be bronchitis, but it could also be pneumonia. It could be a heart attack. It could be a collapsed lung. It could be anything. And we're trained to deal with all of those. And we don't wait for the cardiologist to come in to say, it's a heart attack. We should give, blood thinners or clot buzzers. We don't wait for the surgeon to come in and put in a tube in your chest if your lungs collapse. That's what we're trained for. But I think that is inadequate. Now, if I have had a cough, and I've been coughing for 3 weeks, and I feel a little trouble breathing, but I can walk around and get around my daily life, then that's something that would be appropriate for a urgent care walk-in, or if you're not so sick, you can also, a good thing is to reach out to your provider, your primary care physician or provider, and say, hey, I'm having these symptoms. What should I do? And they can direct you. Well, it sounds a little worrisome. It's 8:00 at night. I can't see you for 12 hours. Why don't you go to the emergency room? Or, you know what? I work with, Jim's walk-in clinic down the street. So they can help derive you, but never hesitate. Yeah. We can see you and provide the care. And sometimes it's just sense of relief and, peace of mind that I'm not going to stop breathing in the middle of the night.
Right. What about sudden or new onset weakness or numbness on one side of the body or slurred speech? That's
an absolute call 911. These are stroke-like symptoms. And stroke care and in cardiac care, heart attack, are time dependent. Used to say when Brian and I were training, time is muscle for heart attack. Now we say time is brain. And there's a number of, during the stroke, you lose something like 4 or 6 million neurons per minute. So there are therapies that we have that can acutely treat stroke now. And so if you have, weakness or numbness on one side of the body, if you have a droop in your facial muscles, if you have slurred speech or can't speak, sometimes even sudden loss of vision, there's a lot of different things. Balance, if you're cognitively, you can't do certain things you normally do, that is an immediate to the ER, preferably 911. Some hospitals are designated as stroke centers, and there's a couple levels. My hospital is a comprehensive stroke center. So if you're in a local area where the local hospital is not a stroke center, the paramedics will drive past it, because every hospital has the clot buster, which you have to meet very strict criteria because it's a very, powerful drug. But comprehensive stroke centers like mine will have a neurointerventional. So besides, you could get the clot buster or not, depending on the condition. But if you we do a very specific types of CAT scans and contrasted CAT scans to look at the blood vessels. And if there's a stroke, which is essentially a clot, and my neurointerventional radiologist will be able to go in there with a catheter and pull that clot out of your brain.
Wow. The
first time I saw that, when we started that, and the neurointerventionalist came in to show us on a little 4x4, a tiny speck of a clot, there's your stroke. It's amazing. So that's something that you should not think about, let me wait, because we have very hard, if you meet all the other criteria, we have 4.5 hours from the time of onset for your stroke that we can administer the TPA or clot buster. Now keep in mind, in patients and occupiers and their families, not every stroke qualifies because it's very powerful blood. So there are conditions, there are medications, if you're on blood thinners, etc. But, if you go to the right place, we can do something else besides a clot buster.
So something else that we've been told should go to the emergency room is a fever with a rash, right? Why is that?
Well, there are a handful of infectious conditions that have very specific rashes that are associated with it. And those are ones that can be very dangerous and very infectious. There are times that we do call a dermatologist into the ER. There's a handful of 5 or 6 conditions, but this especially, there are a couple. There's the meningococcal meningitis, which is a lot of what now you see a lot of public service about getting the meningitis shot before your kid goes off to college, get it. Because there are certain of those that are very serious and very contagious. So, and it's a very specific rash. And you look at it and they say, well, how come you didn't do anything? I said, I looked at you. It's not it. And that's, we'll do other testing. But yeah, if you have rash and fever, it's something that should come in, because those conditions that cause that can be mild, but when they deteriorate very rapidly.
And the one thing that always worries me is abdominal pain. Abdominal pain is always scary until you know what it is.
Exactly. That's number 3 on the ER hit list nationwide. Back pain is the number 1.
I was just going to ask, what's number 1? Because cardiac is
pain.
2. Okay.
Low back pain. Abdominal pain is very diffuse in a description. And it can be anything from I have a upset stomach because I ate 4 pieces of pepperoni pizza, or I'm having my aortas ripping apart. So that's one that's and if it's, new onset, if it's severe, especially if it's associated with fevers, then that's appropriate. And number 2, we're really good at working it up. And there'll be a number of tests that can be done to work up, because there are a lot of conditions. Again, there are a handful of life-threatening conditions, and there's a lot of conditions that are just going to get worse without treatment. And that's one that if it's something different to you, if you have a chronic GI condition, and I think I remember that from the other podcast, gluten intolerant, and you eat gluten and your stomach bloats up and you're pain. That happens every time I decide I just got to have some pasta tonight. Maybe not doesn't have to come in the ER unless you're in pain. Now, again, anything that's causing you severe pain, even if it's a chronic condition, it's not unreasonable to think about coming to an ER. Keep in mind, we don't manage chronic pain. Every state is different. In our state here, there are very specific guidelines and statutes for physicians treating pain, especially with any kind of controlled pain meds. We give them, we have them, we prescribe them as necessary. But we can always offer, and I hate to see a patient sit at home all night, with even simple diverticulitis and severe pain, waiting for their GI doctor to open or their primary to open in the morning. I hate to see you fell and I know my wrist is off and I think I broke it, and just putting ice on it and hoping, ibuprofen will help. That's what we're here for. And we deal with those. And I love sending people home because that means you're not sick, but I can help you. I mean, we can't, even in chronic conditions, I can't cure it. I can do no better than the 7 other GI doctors you've seen in the last 6 years. Yeah. But I can get you some relief for today or tonight.
So what are some things that the emergency rooms do not do?
That's a great question. Keep in mind, emergency rooms, what's available sometimes dependent on the facility and the hospital. I think the expectation for patients should be there's not specialists. I mean, I don't have an ENT doctor sleeping in the hospital to come look at your sore throat. We have them on call. Does that mean I'm going to call them to come in? Only if there's something I can't handle or it's very serious. So if you can't see the pulmonologist for 6 weeks, I can't get you one. Now, if you're sick and you meet the criteria that you would need to come in the hospital, then maybe one would see you, in the hospital. So consultancy is one. A lot of specialized imaging. So we do have MRI available, but it's only available for life-threatening conditions. So even if your back pain has been getting worse over weeks and your doctor says you need an MRI, the chances of you getting one in the ER are slim. Now, if you have certain conditions, you have sudden back pain or chronic back pain, and you have evidence that there's something compromised in your neurologic system or spinal cord, we're going to do it. Certain brain bleeds, certain strokes, certain tumors that we can't image. CT doesn't show us everything, but that'd be based on the radiologist's recommendation. But we're not going to, I can't think as I've ever in 28 years ever MRI'd a shoulder or a knee.
Right.
No matter how bad it hurts. And I understand, I personally have had an MRI on my knee, and I know it took 5, 6 days, 8 days to get an authorization, another couple of days. But, and then other specialized testing, like we don't do echocardiograms in the ER for ER patients. We don't do EEG brainwave testing. We don't do, bone scans. We don't do mammograms. So there are a number of things that we do, anything that's needed to do to evaluate, treat, stabilize the patient within the facilities we have. So I think the biggest thing is, that I have with patients is that the specialist is not going to come in and see you routinely. And if it need to be, yes. But, we can do a good screening exam on pretty much every organ system, every specialty. Now I may call the ophthalmologist, for example, and say, this is what I found. I did the slit lamp exam. I took his eye pressures, and they will say, okay, great. I'll see him tomorrow. Call my office at 8 a.m. Ophthalmologists only come in the hospital for 4 or 5 things, and it's usually somebody they have to take to surgery or treat, but we do the exam for them. So I think that's the big one, and realize that we don't have everything available. Even if your doctor sent you here to get blank, I go, well, we don't do blank. And the other thing I mentioned before is refill of controlled substances. Varies from place to place, but pretty much in our area, most hospital corporate policy, our group policy, nationally, is we don't refill or replace any lost, stolen, ran out narcotics. Mm-hmm. That's a crime pain management's a specialty all on its own. And if you're on those, you have a primary or extender that's very versed in it, mm-hmm. or you have a pain management doctor, and there's whole protocols for those. And it's nothing personal to people, but that's an issue. Now, if you realize today that you dropped your bottle and all your Dilantin for your seizures fell down the drain, yeah, we're going to refill. Or if you run out, we'll give you usually a limited 1-2 week refill to get in. I don't want to see your blood pressure higher.
Right.
That's just going to be more work for me down the line. So, but if you say, we always joke there's a great affinity between porcelain and narcotics because they all fall down the drain in the sink. So, but other than that, but we will treat and evaluate you for your problem. And if there's an issue that needs treatment, I may not be able to refill the prescription. Maybe I can get you something for relief.
Exactly. And I know a lot of times I have patients who they went to the ER and, they come in for a follow-up after and we have to evaluate and see where we need to go next. And I'd say, I catch that they're due for their routine labs. They're like, I just had labs done though. Well, the ER is not checking your cholesterol, most likely, I'm assuming.
No, because our lab will not run cholesterol on an ER order because nobody reimburses that.
Right. It's not an emergency situation.
Right. Now, if you're coming in with chest pain or a heart attack, the cardiologist will order cholesterol screening, probably the wrong screening. Dr. Brian, not the extensive one you do, but they'll do the basic calculated LDL. And the lab will run that on the blood we drew in the ER if they have it. So there's certain things and a lot of tests that you guys order and you would want are just not done stat.
Right. It's like, so some, depending on the situation, you might have to admit somebody. Right. They're put up on the floor then, and then they can have their follow-up lab work or procedure the following day or the next day.
Exactly. And, some of the lab work our hospital does is not done in the hospital. It would be sent out to a specialty lab. Mm-hmm. Others are just batched once a day. Mm-hmm. So, I can get a TSH and a T4, but the T3 is only done once a day. Just listen to your great thyroid podcast the other day. So it's, that. And again, the purpose of the ER is to treat and evaluate for the sickest patients. And what we do is to see if you have an emergency condition. Is it something that needs hospitalization? And the point of hospitalization is to provide care that can't be provided elsewhere. And unfortunately, in this regulatory environment, Medicare, Medicaid, insurances a lot of times govern what is paid and not paid. So just because the other night, an elderly patient came in with COVID, was sick, had fever, felt terrible, but did nothing else. I said, "You got to go home." He goes, "Well, I don't want to go home. I feel bad." I understand, but what am I going to do in the hospital? The nurse is going to give you Tylenol, going to bring you 3 meals a day, and you're going to potentially spread COVID to five other people, so there are, but we will always see and evaluate, and that's our job, is to figure out who's sick and needs to come to the hospital, figure out what's wrong, who's not so sick, who we make feel better. I may make the diagnosis, but I'm going to tell you, go follow up with your smart primary doctor. He'll figure it out.
So let's shift gears now and talk about urgent care clinics. What are urgent care clinics?
So urgent care clinics are a type of freestanding or walk-in or clinic that exists in a number of areas. It could be in a shopping mall. It could be associated with a doctor's office. And typically they are designed for simple things. Just, do I have a sore throat? Do I have cough? Do I have burnt in the urinate? Hurt when I urinate? Do I have back pain? Did I sprain my wrist? And those are the kind of things that they are staffed sometimes by some brands, some companies brand that they have doctors, and they put that in the title. I won't name it, but doctor here. A lot of them use physician extenders or nurse practitioners specifically, and that's very good for cough, cold, sore throat type of things. And they do have some testing available, typically very basic point-of-care testing. So we can test to see, if you have dips, if you're in your analysis, we can do a pregnancy test, we can do a strep test, a COVID, a RSV, a flu. Some have some imaging available, so they'll do simple chest x-rays or bony x-rays. Some will order more extensive labs to be sent out, so you won't know for a day or so. And those are good, and they're very good. Some have IV capability to give you IV fluids or IV antibiotics. And then a lot of them are associated with different medical practices. So if you come in because you don't have a doctor say this, but Dr. Jones is who we follow up. And then beyond that would be what's called a walk-in clinic, which is very similar, but doesn't really have maybe all the imaging. And those are fine for, I need to get a tetanus shot for work. Sometimes they'll be used, I slipped and I hurt my wrist at work, and the workman's comp is here. I've used them for my own children to get the physicals they need to participate in sports and school or travel sports. So those kind of things are good. All of them are good to do a screening, and they're one of our best referral sources.
That's the good thing about walk-in clinics. I think they know their limitations, right, and they're basically for the convenience, I think, to access like same-day appointments and for minor things like you already addressed.
Yeah, and we tell our patients, use a walk-in clinic if you cannot get in to see your primary care physician, because your first point of care should be your primary care physician. They know your history, they know your allergies, they know more about you than someone who's never met you before, right? But it's a good backup to have on hand. And it's typically a good option if you're not feeling well, but it's not serious enough for the emergency room or urgent care center.
So, go ahead.
I was going to say, you brought up a point that wherever you go, main ER, freestanding ER, urgent walk-in, there's certain things you need to either know in the back of your hand or put them in your phone. There's many apps. I love lists. So when you go in, either you or your caretaker or your spouse or whoever, you should basically bring some things you think are simple, but what are your medications you're taking, the current ones? It's in my chart. Look, yeah, you were hospitalized 16 months ago. I'm sure they've changed these.
And supplements too, not just medications.
Absolutely. Supplements have a lot of effects and interactions. A list of your medical problems or conditions you've had or surgeries you've had, list of allergies, and, your doctor's name and number if you have it. We know most everybody, but, I get, it's that guy, that Puerto Rican guy, he's on Atlantic Ave Boulevard off of 3rd Street. I don't drive around and look at people's offices.
Right.
So those things can help, because even if a physician's not on staff at that facility, or if you're in urgent care, there's times very frequently we reach out, we call, we talk to them. Hey, your patient's here, has this. They don't know that their kidney function is off. Is this something you know about?
I think everyone should have all these things written down long before they ever need them, and put them either in their wallet, in their car, somewhere where it's readily accessible. Give it to your partner, your spouse, your family member. Make sure someone else has a copy, because you never know when you're going to need these things. Even when they come in to see us in our office, we need these things.
I always recommend to have it in multiple places, because say you're at your house, have it on the fridge or put it somewhere where the EMS, if they have to come into the home and get you, or paramedics, they need to know where this is so they can bring it with them as well.
That's very common. You see, I think one of the first things hospice tells patients, here's this packet, but here's a copy of your do not resuscitate order and your medications. Put it on your refrigerator, because the paramedics know to look there. Mm-hmm. I see a lot, smartphone apps come, the iPhone, for example, comes with a place to put it. There's lots of them that you put your medications, and we know to look there. And a lot of my patients who maybe are not so tech savvy, they just have a little note, they type out on the computer a little Word document, and they have it folded up in their wallet.
I have a question. So is it beneficial for an ER physician to know what previous procedures they've had done, like surgeries?
Absolutely.
Well?
Absolutely can affect everything. We talked about abdominal pain. If you've had 6 different abdominal procedures, I'm going to approach this differently. There's different things. I have to look for bowel obstructions. We have to look for different. So anything you've had, you come in and, also non-related, you come in, I think you have a stroke. Unless you tell me, well, I have a knee replacement, that can affect your ability if you have an MRI or not. Now, most implants these days are MRI compatible, but some older ones not. But if you tell me they put rods in my, back 30 years ago, the radiologist is going to go, oh, no. And it's serious, and I'm not just nitpicking, because MRI, the first M stands for magnet. It's a large magnet. And if there's metal in you, whether that's surgically implanted, whether it's shrapnel from being shot, being in combat, living in the inner city, even if it's, I have a foreign body that I stepped on something and I had this piece of metal and the doctor says, not bothering you, we're not cutting it out. We got to know that because that metal can move in the magnetic field or it can just heat up. Mm-hmm. And so there's there's been a lot of cases of bad outcomes. Now we do big screening and we talk to everyone we can, family members. There's times when we essentially do almost a whole body x-ray if we don't know to see if there's any major implants or metal in a body. So those things are important. So your whole medical history. And going back to what we talked in the beginning about knowing what hospitals do what, it's probably also a good thing to know what hospital does your primary care team go to. Now, that doesn't affect your care, but it'd be nice to know that, my cardiologist comes here so that if I need a consult, they can see me. Or at the least, and I know most primary care doesn't admit anymore for a lot of good reasons, but it's easier when you know the people in the hospital and they know you, and they'll reach out to you and say, and you'll say, yes, I know about his thyroid function. It's been off. We've done this, and this. That keeps you from one, having that done again unnecessarily, but also can kind of get to the main problem quicker and can be better for follow-up.
It's more streamlined.
And when you go, everything we do is on the patient portal. But getting access with privacy laws between series. But if you're on that staff of the hospital, I can sit there on my iPad at my dinner table and say, oh yeah, well, the potassium came down. Look at it and know my patient. Otherwise, it's like the patient, and some patients are portal savvy and have it. Some have no idea. Mm-hmm. So it saves you your office staff from call the hospital, sign a release, fax. I don't know if medical records can get it to us that day or so, and it can so that your primary treatment team can see what happened, what they did, what else I may need to do or not do, and what needs further workup. So it's just better care all around.
So many people don't know that there's a strict law that governs the way the emergency room works. So why don't we talk about the Emergency Medical Treatment and Active Labor Act of 1986?
Correct. EMTALA. Originally, before that, it was COBRA. For a few years later, Combined Omnibus Reconciliation Act, I think. And it's the Non-Dumping Act. So in the 70s, up into the 80s, it was not uncommon, especially in larger metropolitan areas of multiple cities, that if a patient came in the ER, was not insured, and it was a private hospital, they would not treat them. Or they would say, you need to go down the street, to County General. And patients would have bad outcomes. There's been, there's been news reports of somebody walking into a, private hospital in Chicago, shot in the abdomen. They said, no, the trauma center county is 2 blocks down. You got to get out of here. So what EMTALA says is that it mandates every hospital that has an emergency room. It is limited to patients that participate in, limited to hospitals that participate in Medicare or Medicaid federal funding. So something like Hospital for Special Surgery or one of those specialty, orthopedic or wouldn't be, but they don't have an emergency room. They have an intake area. But if you come to the emergency room, EMTALA governs that we have to provide what's called a medical screening exam. That could be provided by the physician. It could be provided by an extender. And the whole purpose of that exam is to determine if you have a emergency medical condition, which is a life, limb-threatening or serious condition, including active labor. And this is done without regards to ability to pay, not pay, insurance, not pay, everybody. And we have to do whatever we would normally do on any patient to determine if that emergency medical condition exists or doesn't. So I'm going to CT your belly if you have Blue Cross, but if you're self-pay, I'm not going to CT your belly. No, we're going to do the same workup for everybody. And then once we determine there's a condition, we either have to be able to stabilize it, treat it and stabilize it to a point where you're safe for discharge, or we have to admit you to the hospital regardless to pay, or we have to, if we don't have that capability, we have to transfer. And there's a portion of EMTALA that covers transferring patients from hospital to hospital. I just can't call up a private ambulance, roll you out of the ER and say, take them to County General, they're having a stroke. So what it requires is that the hospital I would like, either the patient can request, I want to go to, Sister Mary Jo's Hospital or Holy Cross Hospital or any other brand name. First off, the hospital has to have the capability and capacity. In other words, we offer the service you need. They also have to have room. They have to can't be full. And there has to be an accepting physician. So you have, and a lot of times that's not an issue, but if you have a complex medical condition and you don't like my hospital for whatever reason, and you have no doctors at another hospital, they may not necessarily be obligated to take care of you if we can. Now, if you're going from a hospital that doesn't have the services you need to a higher level of care, then I have to accept it. We accept patients. A patient flown in with a heart attack the other day from out in the middle of the state on Lake Okeechobee because he had a heart attack while he crashed his car. So we take him, no questions asked. So EMTALA basically for the patient means you're going to be seen and you're going to be evaluated. You'll be stabilized and treated without any regards to your ability to pay or not pay. And then once we know what the condition is, then the options, if it's somebody I would send home, you're getting sent home, with prescriptions, with medications, of course. If it's someone that needs to come in the hospital, we will admit you to the hospital. Our hospital doctors will admit you. Now, the hospital or the different physician groups probably will, submit a bill. But if you come in and let's say you have a complex urologic condition, you go to a well-known national brand hospital that has a hospital in the next county below us, known for their complex urologic stuff, and you want to go there, okay. We can arrange you. Now, EMTALA also means if you're transferred, you'll be transferred by ambulance. We're not going to put you sick in the back of your car with a sheet of. It also says if I transfer, I have to send all the copies of everything I did, all the disc of all the imaging, copies of all the notes of the blood work, et cetera, so that care can go on, can continue on. So it's a safety net. And the ER, we do a lot of primary care. I know I've been to some educational lectures and dinners with Dr. Brian, and they go, oh, your ER, I don't know. He goes, who do you think starts the diabetic med on a new diabetic? Who do you think picks the blood pressure medicine?
Right.
They'll come into Brian and he'll say, Larry, we don't use that. That's old school, or what are you doing? But we pick the start. So,
you are the second best at everything.
I am the second best. There are some things we're first best at. Uh-huh. There are subspecialties, I kind of alluded with it, but there are subspecialties of emergency medicine, like toxicology, poisonings.
Yeah.
We've had some really complex poisonings recently.
And overdoses, I'm sure.
Overdoses, yep. All of that, things like, diving medicine or hyperbaric. So there are things that we do that are unique. We're good at getting things out of people. Mm-hmm. I personally am the fish hook king.
Oh, okay.
I have about 4 different ways, and it's just something I'm good at growing up here and training here. So that's the thing. Most people come to the ER and no, we just don't cut it out. That's my last choice. There's a few tricks. So there are a lot of things and there are some simple things like that would be appropriate. And kind of going back to you, Sam, Brian, obviously walk-in and urgent care a lot of times are the first choice, but we are conscious that there are times that that's not an option. So over, say, a long holiday weekend and everything's closed. Even the urgent cares may be closed on a holiday, and they're not. There are some that are open all hours, and there's some they're not. So if it's the middle of the night and you think it's something you can't wait to the day, that's okay. We'll take care of you, And, but again, there is a real cost difference, even with insurance coverage. So that's something, if you think it's just a minor cold, your copays and that you may need to pay and the overages may be a little more.
Yeah. Again, call your primary care doctor first if you're in doubt. Right. This has been excellent. We've really enjoyed having you on here, and I think we're going to have you on again, maybe to talk about hyperbaric medicine and maybe even wilderness medicine, which is another topic that you're very interested
of mine. Yeah, it's love to, Brian. It's something I always when we have our residents come through, I always give them once a year at our local university. What was the name? Local university ER resident. I give a couple lectures on wilderness extreme medicine, diving medicine, because even if you live in Upper Peninsula, Michigan, people are diving in any puddle of water. But nowadays with travel, I could be doing a week of diving in Roatan, and 12 hours later, I'm back in Poughkeepsie.
Right.
And that's when I get a problem. And you hope that doctor you go see in the ER knows you were diving. I wonder if that's a problem.
Right. I think that definitely helps you in your field to be to have that experience. Well, thank you, Dr. Roycraft. It was a pleasure.
Pleasure as always, guys.
Thanks.
Thanks.
The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.